Hey everybody, I'm posting a new video because we are about to um, increase the availability of buprenorphine for two different populations. So one population would be ER patients and the other population would be inpatients. And so I wanted to put together an introductory video for the staff, both the nurses and pharmacists and physicians at our facility, so that they can get up to speed with what this new policy means and what considerations that you should have for dosing, etc. So the first thing is to describe buprenorphine. So buprenorphine is an opioid, and so when you take the opium poppy pod and you take the juice out of it, it has morphine in it, codeine in it, thebaine in it. And thebaine, if you chemically modify it one way, you get oxycodone, which is a full agonist opioid. And if you chemically modify thebaine a different way, you get buprenorphine, which is a partial agonist opioid. So on a nerve cell, which I'll show you as my fist, there's a receptor called the mu receptor. And every opioid that you've ever heard of, except for buprenorphine and another medicine we have in the hospital called Stadol, or butorphanol, so most of them will fully stimulate that receptor, giving you pain relief and CNS depression, respiratory depression, and increase the chance of overdose, etc. So we have to be cautious with opioids. Now, buprenorphine and butorphanol, which is Stadol, are what are called partial agonists. And the reason why we use Stadol in labor and delivery is because when you give it to laboring women and the baby's born relatively quickly thereafter, because it's a partial agonist, you don't get as much respiratory suppression in the newborn baby. But if you do, you can just always reverse it with naloxone injection. Buprenorphine, although you can give it intravenously like butorphanol, for our purposes is only available as a sublingual dosing. In the hospital, we'll give it as a plain 8 milligram tablet, which you can cut down or take multiples of depending on what the dose requirement is. But that's the one that's on formulary at this time. Although patients may bring in their buprenorphine prescription or whatever, it comes in multiple forms, multiple names. There's like 9 different forms of buprenorphine on the market right now. The problem with dosing buprenorphine is that while it's still an opioid and you need to be careful with mixing it with other CNS depressants such as benzodiazepines and any other sedative pretty much, the main concern is not the risk of overdose. It's actually very, very difficult to overdose on buprenorphine. You have to take multiple CNS depressants, and it's much, much safer than every other opioid. So that's the plus, and why it's prescribed to people who have an opioid abuse problem, is because they can take it and stay out of withdrawal, and the risk of overdose is much, much lower. I've had patients take 5 times their usual dose of buprenorphine in an attempt to do whatever, and have not had problems with injury to the patient, etc. So that's good. Now, the issue is that you can't have a full agonist opioid in your system and take buprenorphine, because what will happen is that the full agonist opioid, let's pick morphine, is on the receptor. Buprenorphine will come along and has higher affinity for the receptor, meaning it'll kick the morphine right off, and it'll bind to the receptor instead, and that receptor and any of the other billion receptors, opioid receptors in your body, will go from full stimulation down to partial stimulation, and people will go right into withdrawal. But in a person who is already on buprenorphine or who is in withdrawal already, substantial withdrawal, the buprenorphine will take them right out of withdrawal, and they'll feel well very quickly. So the buprenorphine is prescribed sublingually. If you swallow it like a pill, the medicine dissolves in the stomach. It goes into the blood vessels that go right to the liver, and the liver destroys virtually all of it in what's called first-pass metabolism. And buprenorphine has a high degree of first-pass metabolism, so you cannot swallow the pill. However, if you put it underneath your tongue and it's dissolved and absorbed into the blood vessels underneath your tongue, it goes down your jugular, right to your heart pumps it back up to your brain and everywhere else, and boom, it works great. So you have to let the pill dissolve completely so the buprenorphine is floating in the saliva, and then it has to be absorbed over time from the saliva into the blood vessels. Typically the tablet takes, if your mouth is wet, 10 minutes to kind of release its medicine and completely dissolve, and then typically another 10 to 20 minutes to be fully absorbed into the blood vessels. So you have to have the patient place the buprenorphine in the mouth after they have sipped some water or something, because some of, especially like an older patient or a patient that's dehydrated or whatever, if your mouth is dry, it's just not going to dissolve very well at all. So make sure that they have a moist mouth. Place the buprenorphine sublingually. If you can crush it if you want into a powder that can speed. So if, like, for example, a patient says that they have a hard time holding the spit in their mouth for a while, crushing it or cracking it into smaller pieces can speed the time it takes to release the buprenorphine into the saliva, but it still takes some time for the buprenorphine to move from dissolved in the water in your mouth, the saliva, into the blood vessels. So the minimum amount of time, even if you crush it very finely, would be an additional 10 to 20 minutes after you put the medicine underneath. But typically for our purposes, you're going to put the whole tablet underneath the tongue, and you're going to have them close their mouth, do not eat, do not drink, do not spit, do not talk, do not swallow your spit for 30 minutes. And then usually if they're sitting up, because if you're laying down, of course, that spit will kind of go down, and just reflexively you'll swallow your spit. And as you swallow your spit, you're swallowing the buprenorphine down, your liver destroys it, it's not going to work. So they have to be usually sitting up somewhat, chin down, mouth full of spit for 30 minutes and get that full absorption. Now, typically, the effect of the buprenorphine will start as early as like 15 or 20 minutes. Peak effect is, I think, 90 minutes after it's placed underneath the tongue. So people will come out of withdrawal relatively quickly. Now, if they're not in withdrawal, or if they have long-acting metabolites, for example, methadone metabolites, typically people have to be off of methadone for something like 7 to 14 days before they can be switched over to buprenorphine. Otherwise, you will cause what is called precipitated withdrawal, where they'll put the buprenorphine underneath their tongue, and like 25 minutes after they put it underneath their tongue, like a sledgehammer comes down, and they start sweating and vomiting and diarrhea and just the muscle twitches, and it's really, really difficult. And some of you who've been here at the hospital long enough probably remember years and years ago, I actually had a couple of patients end up in the emergency room after precipitated withdrawal. And since then, I've changed my protocol in the farm, because I had one patient, tell me that it had been days or whatever, weeks since he took methadone. It turned out after he took the buprenorphine and precipitated withdrawal, he's like, oh, I took one this morning, I thought it'd be fine. So, at that point I was like, if there's methadone in your urine at all, I'm not giving you buprenorphine, because I never want to see somebody in the ER again. It turns out that patient's still one of my patients, and he's doing well. So, just because they have precipitated withdrawal doesn't necessarily mean that they're never going to come back for treatment, but, it certainly is very, very difficult to manage. There's really no way to undo the buprenorphine regardless. So that's kind of like the main things with buprenorphine. Buprenorphine, like oxycodone, does not have substantial drug-drug interactions other than the fact that it is a CNS depression, although to a much lower degree than any other full agonist opioid. But those are kind of the main considerations. So let's talk about patient populations. So this new protocol allows physicians in the ER and physicians in the hospital, pretty much any physician, to prescribe, let me take that back, not prescribe, but to administer buprenorphine in the hospital for withdrawal control for 3 consecutive days once in that person's life. okay? So this can't be something like you do 3 days and then a month later the patient comes back and does another 3 days. They get one chance. Now, during that 3 days, hopefully, they are able to get into my practice or to see Dr. Dupree or see Dr. McKenna or Dr. Dempsey, an outpatient provider. Now, there are several hospitalists and ER physicians who have either received or are working on their Suboxone license, which is a special DEA license that allows you to prescribe it, and then the patient can go to the pharmacy and pick it up. But if you don't have that, there is an opportunity for patients who come in, let's say a patient who is ready to get help, they have been using heroin, and they come into the ER in fulminant withdrawal. They're just sweaty, pupils widely dilated, they're nauseous. You go through the COWS thing and they're in moderate to severe withdrawal. That would be a great candidate to give a buprenorphine dose right then. And you would, it takes some figuring out, okay, what is the right dose? How much have you been using? So sometimes a phone call from one provider to another, just call any of us 24/7. I got this person that they say they're using this much or, whatever, let's get the dose correct. And then you give them, for most people, it's going to be a substantial dose, like 8 milligrams. Or more. Usually the studies have shown that maintaining people on 16 milligrams or more per day of buprenorphine results in long-term improvement in control of their opioid dependence. So nowadays we tend to be prescribing higher doses of the buprenorphine. So that's kind of the case for the ER. And then let's say it's a Friday night, they come in, you can go Friday night, Saturday night, Sunday night. Those are your 3 days. And then hopefully on Monday, they can be just squeezed into some practice. And, hopefully there's a phone call that says, can you squeeze this patient in to whoever. Certainly, if I'm around, please give me a call anytime. And usually I'll just say, we'll have them show up, at 8:30 in the morning or whatever, if I'm in town. Otherwise, there are other options. But this allows us to kind of bridge people into an outpatient practice, and then they can get referred to a substance abuse program, because buprenorphine all by itself is not recovery in a bottle. And a lot of people act like it is. They get a prescription for buprenorphine and instructions, okay, go to this intensive outpatient program or see this counselor or begin the process of getting into a residential treatment program, and they just don't do it. So that is common. And it kind of takes time for people to kind of admit that, they need to do something more than just take buprenorphine, but, that's a discussion for another day. So on the inpatient side, let's say a patient's admitted for pancreatitis or a pneumonia or whatever, and they have an opioid dependence problem. You can also start buprenorphine as an inpatient and for the treatment of opioid dependence. And there is a protocol here. And as it is right now, what we're trying to do is make sure that the majority, if not all, of the hospitalists have their DEA license, so they can, they not only can administer it in the hospital, but you can also prescribe it for them to leave. And but still, you can always do the 3-day rule until another appointment is made for an outpatient. So recently, one of my patients who I haven't seen in several years was admitted to another hospital with a huge infection in the arm from injecting heroin. So they kept him in the hospital for 5 days and then discharged him and sent me a discharge summary. And so I called the hospital and I said, can I speak to so-and-so patient? And the patient had left already, and I called all of the numbers we have, no ability to contact this patient. That is an extraordinary missed opportunity to restart the patient on buprenorphine, because now the patient's gone. We haven't heard from him in the clinic, probably back to using, and that was a great opportunity to start the patient on buprenorphine. I was in the hospital for 5 days. All they had to do was, call another provider. I mean, that was just a great opportunity. So I've reached out to the medical staff at this other facility, trying to make sure that they understand, there's a better way to do it. And so hopefully they will initiate a similar protocol. So we don't have this problem where patients who are clearly suffering from limb-threatening and potentially life-threatening complications from their opioid dependence problem are not given the best treatment that we have, which is buprenorphine. The withdrawal is typically severe for several days, but it continues on afterwards. And so although people can just cold turkey kick opioids like in jail or something like that, just the data is that people do not regularly stop using opioids without some help. And the buprenorphine is a great tool for it. It's very safe. It is regulated. As I mentioned, you need a special license to prescribe it as an outpatient, but in the hospital, it is for patients who are inpatient, who are either already on buprenorphine or need to start buprenorphine. Let's make this happen. Let's make sure that the ER patients have the 72-hour rule initiated. They can get buprenorphine for 3 consecutive days, helps us bridge them into an outpatient practice. For inpatients who are admitted to the hospital, let's start them on buprenorphine if they're a good candidate, and then again have them transition over to an outpatient practice, and hopefully reduce complications, reduce infectious disease, overdose deaths, incarcerations, etc. This is the goal. So hopefully that's helpful for everybody to understand a little bit about buprenorphine and how we're going to use it at our facilities. Thanks so much.